We help build a better future when we harness the power to develop new ideas. The power to demonstrate what we're made of. To be the role model our community needs. To be recognized for who we are and what we do. The power to have the same opportunities as everyone else. To break ceilings or to build bridges. To make things happen. To start something new. ¿Y tú? ¿Qué quieres lograr? What would you like the power to do?
Thank you for joining us today. My name is Andrea Womack, and I am Bank of America's Dallas and Fort Worth Markets HR Executive. Bank of America is proud to return as statewide sponsor for Big Bang. The work of social venture partners brings people and partners together to address the effects of systemic injustice, as well as paths towards change. Their work often drives powerful conversations about racial, social, and economic equity. These topics are equally important to us at Bank of America as we continue to invest our $1.25 billion commitment in partners and opportunities to advance racial equality and economic opportunity across our country. At the end of August, Bank of America announced a $1.35 million commitment in support of mental health initiatives focused primarily on young people of color. This commitment is equally as important as the commitment to mental and emotional well-being of our teammates navigating the pandemic. This unifying call to action is why we're here today. We have the opportunity to hear from Andy Keller from the Meadows Mental Health Policy Institute, Dr. Trivedi with UT Southwestern Center for Depression Research, and Margaret Black of Lyda Hill Philanthropies as they discuss the Lone Star Depression Challenge, the impact of winning the $10 million Lone Star Prize, and the work they will be doing across the state to combat mental health issues. Margaret, as director at Lyda Hill Philanthropies, thank you for your commitment to mental health issues facing residents of Texas.
Thank you, Andrea. As Andrea said, I'm Margaret Black with Lyda Hill Philanthropies, and Lyda Hill Philanthropies encompasses the charitable giving for our founder and Giving Pledge member, Lyda Hill. It's an honor to be here today to introduce our panelists and the team leading a truly game-changing initiative in the field of mental health. The project you'll learn more about today won the $10 million Lone Star Prize, which was a Texas-based competition sponsored by Lyda Hill Philanthropies and guided by support with strategic partners like Lever for Change, Texas 2036, the DRK Foundation, and our friends here at the Texas Tribune. The prize was designed to surface a pipeline of philanthropic big bets for Texas. And it was to encourage leaders to think big and to challenge the status quo in 3 areas that we know are critical for Texas's future: boosting the workforce, protecting the environment, and improving health systems. Of course, when we began designing this prize way back in fall of 2019, we had no idea that the pandemic would exacerbate these statewide challenges and bring an urgency like never before. Lone Star Prize applicants illuminated the great work happening all across the state. And in fact, more than 172 proposals were submitted, and over 200 peer applicants and expert evaluators weighed in through a very rigorous review process. They evaluated applications based on 4 criteria: whether the proposed idea was transformative, scalable, feasible, and evidence-based. When the winning proposal, the Lone Star Depression Challenge, was announced in June, The other 4 finalists also received some funding to jumpstart their bold solutions. And all of these shovel-ready ideas for Texas are now featured in the Bold Solutions Network. The winning proposal by Meadows Mental Health Policy Institute was by far the highest rated proposal reviewed by our external evaluators. And while Lyda has been funding mental health for many years, there is something significant about this project rising to the top and to the forefront of the moment we're living. At its worst during the pandemic, rates of depression and anxiety skyrocketed 4 times their normal level. Even more recently, it's estimated that 1 in 5 adults exhibit symptoms of depression. And while it's perhaps perversely encouraging on some level to witness that there's this mainstream attention now with headlines on the topic of mental health, responding to this issue broadly will demand systemic change. So before we hear from our panelists, we just wanted to emphasize how important mental health is for our state and the moment that we're living, and how fortunate we are that, first of all, that we even have a promising evidence-based strategy, and that the plan is funded, and that it's happening, and that the plan is collaborative in nature. It's anchored by institutions like UT Southwestern, Harvard Medical School, and Meadows Mental Health Policy Institute. And just that this transformative potential of this project goes beyond the state lines. There's certainly something special about Texas's diverse demographics and economics and geographies that make it a really wonderful testing ground. Now, we know complex problems like mental health often require a multi-pronged approach. So you're about to hear that the Lone Star Depression Challenge is really 3 initiatives wrapped into one, with strategies for primary care, harnessing market forces, and addressing the need for culture-spanning community health workers. On behalf of Lyda Hill Philanthropies and the Lone Star Prize, I am pleased to introduce 2 of the architects of a very bold solution, Dr. Andy Keller, President and CEO of Meadows Mental Health Policy Institute, and Dr. Madhukar Trivedi, Founding Director of UT Southwestern Center for Depression Research and Clinical Care. Thank you both for your partnership.
Well, Margaret, thank you so much for letting us be here today. And thank you so much for, first of all, running such an amazing process. It really was. We actually got better through all that competition. We had a good idea to begin with, but all that competition really helped us sort of like bring in even more and bring our best ideas there. And you all, I mean, the vision you set for this and the investments you've made, I think we're gonna change a lot of lives. So thank you so much. So I'm here today with my friend Madhukar Trivedi, and we're not gonna call each other doctor, are we? We're just gonna Andy.
No.
Okay, good. So we're gonna have a conversation today about this, and we really wanted to kind of take you a little deeper because we have a chance to have a conversation. I wish our friend and colleague Vikram Patel, who represents that 3rd institution, Harvard Medical School, and yes, it's the Harvard in Massachusetts. That's the one. You may have heard of them, but this is the UT Southwestern team and the Meadows team here representing the whole project, and we'll try to get into all of it. But I thought, Madhukar, we could just talk a little bit about kind of what this is like, and I think you and I haven't had a lot of chance to just sit down, the 2 of us. So in some ways, this is an overdue conversation because we've been running, trying to get this thing done. So what I thought I might do, Madhukar, is just remind you what we promised in the bottom line of this and let you reflect on that. So we told the Lyda Hill folks that for depression, and we're going to talk a little bit, I thought Margaret did a great job talking about the impact of depression. We'll talk some more about that. But the hopeful thing we told them is that in 5 years, we're going to save over 1,000 lives who otherwise would have been lost to suicide. And we're going to help at least 10 million Texans have health systems where if they get depression, they have a more than 50% chance of getting better totally. And we're going to help at least 1 million Texans during that time period through this initiative recover from depression and build momentum towards having one day every Texan have access to state-of-the-art depression treatment. So that's what we promised them. So when you hear me say all that, how do you feel? Does that make you feel like a lot of pressure? Does it make you feel, how do you feel?
I think that I feel really privileged that both through our partnerships and through Lyda Hill's really imprimatur, this is giving us a chance to stop this pinprick solutions we have always done to making it a big deal, making it comprehensive. And task that is at hand actually in some ways is really wonderful, because this will allow us to transform it rather than just do a little bit at a time.
Yeah. Well, and I think that's the thing I hope people take away from this, is that we can't keep doing more of what we currently do. We got to transform our approach, which we've done for other health conditions. We're going to talk about that. But I want to go kind of back, because you and I are both clinicians. I'm a psychologist, you're a psychiatrist. We both have specialized with people with mood disorders, and which depression is a mood disorder, like bipolar disorder is a mood disorder. And I want to talk kind of back in the day when we were getting trained. One thing for me, like I got terrible training on this. Like, for one thing, like I was never told like how many people I should expect to have depression. Nobody ever said, how do we treat everybody? But even more than that, like one of my supervisors, actually a lot of my supervisors would say, well, if you actually help people have their symptoms be reduced too soon, they'll lose the motivation to make meaningful change. So this is like the early 90s, I'm being told this. And I assume you had similar, misinformation given to you as a physician?
Absolutely. And I think there is this myth that you don't necessarily need to have sort of routinized measurements or similar approaches we take with high blood pressure, with diabetes, with asthma. This is special. But in the process, I think we lose some fundamental facts, so that you have to measure things, you have to guide both the treatment and keep track of what is going on, so that you look towards a target. It's like the Wild West, where people used to drive without having GPS, and that's really been unfortunate, because what then does is it builds in a cycle. We don't actually use any kind of evidence-based approach. Patients and the community feels like this is a little bit hocus pocus, and then it continues to kind of snowball, and our patients don't get better. One of the fundamental things we hope to change totally is, currently in the United States, half the people with depression never get diagnosed. The other who do get diagnosed, half of them don't ever get onto treatment because of all systematic changes. And then only 6% of people get fully recovered. And I think that should be unacceptable. And this approach that we have been promising is very reasonable, very easy to do, and it's going to change it totally. It's going to require all our partners in health systems and community leaders to want to do it, but I think that's the work we have ahead of us.
Well, it's just going to be fun. And I bet, I think part of the reason, we were trained the way we were, and other folks have been trained similarly, is I truly believe, and I don't know if you agree with this, I think a lot of us just don't grapple with the fact that these are diseases, that depression is a disease. I think at the bottom line, people still don't want to think that. They want to think, well, we all get blue, and, we all are sad sometimes. We don't want to recognize that these are treatable diseases that people can get better from, but you got to do treatment. You can't just, do an art. We're not going to be artful with the person and, help them talk about their childhood or do whatever. So, I mean, don't you think?
I think you hit it on the head. On the one hand, we don't feel like it is a disease. It's sort of maybe just the ups and downs of life. On the other hand, the other side of it, people believe it's so complicated and so black box that nobody knows, and you just need very highly qualified specialists. And I think we have not recognized that it should be seen, like you're saying, any other medical illness, and follow the same pattern we do with other medical illnesses.
I think you make a really good point, that I do think we're really scared particularly of suicide, because I think that's the other side. It's so scary, and it's such a horrible thing to live through. We don't want anyone to have to suffer that. And so then we end up actually putting people who are at risk of that, leaving them alone, and families who experience that, making them feel like they can't really talk about it. And, and I think one thing that you and I've talked about is how that used to be how it was for cancer. It used to be folks didn't talk about having cancer back in the, before the 70s when treatment started improving. So I think we forget sometimes, I think, that we're not the only set of disorders that used to be treated poorly. I mean, cancer, heart disease, a lot of things we didn't treat that well before we made some of the changes you're talking about.
And we have changed it. A 45-year-old today, when somebody like you or I just put a hand on our chest and say something's wrong, 10 people around us will say, go see a doctor, go get an EKG, go get a measurement of blood pressure. And that is how we have changed heart disease. With depression, when somebody says that, then you look for 33 reasons why. Maybe it's the job, maybe it's the spouse, etc., rather than say, go see somebody and get evaluated. exactly what you're saying is either it's a black box or it's not a big deal. And in the process, we ignore a whole lot of it, which we have to stop.
Yeah. Well, let's talk a little bit about kind of how care is now. And, one of the things I think that we've kind of hit upon is that right now, if you have depression or other mental illnesses, but we're focusing on depression, it's going to be years, maybe even more than a decade before you get any help. And I was reminded that how in my family, the experience of heart disease is like that. So my grandfather actually died of a heart attack in 1976, but they resuscitated him. And he was in a coma for a couple of weeks. But when they sent him home, that's when they put him on a low cholesterol diet. That's literally when they diagnosed his heart disease. And I think in some ways that's very analogous to how it is today, that it's a crisis, like somebody's in crisis before we get them help. And I'm sure you see this at the clinic, that you've got people coming into your clinic, they're for the first time coming for treatment because they're now suicidal, they now have a crisis, they're out of work. I mean, a lot of bad things have happened. And basically what we're talking about is standing that on its head, is not waiting 8 to 10 years. It can, and Madhukar, you did those STAR-D trials. I mean, you led those, those early trials that really established the benchmarks for depression treatment. How, can you talk a little bit about that whole early detection piece that you guys pioneered on that, and that you've now replicated hundreds of times over and shown the efficacy of?
Absolutely. And I think that was, again, a very large 40 million NIMH study, because what we promised NIMH at that time, NIH, was that instead of what people used to do before then, where you wait for people to be in a crisis and then study things, we said we are going to go to the community. We're going to go to primary care practices. We're going to go to psychiatry settings, routinely screen for people. And those who have depression will go into a multi-step treatment approach like we do with diabetes or heart disease. And we then put in tools necessary for both primary care and psychiatry for measurements of symptoms, function, as you were saying, work productivity, et cetera, and guide treatment based on evidence. And we produced several things, but one fundamental thing was, if you use these measurements, outcomes can get to 70, 80% improvement, which is what you've repeatedly talked about, that we have currently treatments we don't use. We need to put it in practice.
Yeah.
The second thing that was fundamentally life-changing in my view is we showed that if these tools are used by primary care physicians, the outcomes for patients in that setting are exactly the same you get in psychiatry. So this does not require to be waiting for somebody to go only to a specialist. Some patients will need to go there, but that needs to happen in a sequence rather than start there.
So which is similar, like heart disease. So like my doctor started haranguing me about my cholesterol when I was 30. And so I've now had many decades of being told my cholesterol is bad and given, not really treatment. Well, I guess each year we work on strategies to get it lower and to use exercise and diet. So I've been in treatment, I guess, even though I don't have I'm not going to have a heart attack yet. And
well, you should thank your doctor, because maybe that is why you're still alive. And
I think that is. I guess that's basically what you're doing, right? You're basically saying to people, let's find it early on when you first have those symptoms, when they're going to be lower. And it's interesting, I don't think anybody ever taught me that like when things first develop, they're less hard to treat, less debilitating than if you wait. I mean, it's obvious, right? But that wasn't part of my training. Was that part of your training? No,
and we have research now, and we published on this, where if somebody has depression and they go untreated for 10 years, it has a very toxic effect on the brain itself, so that then the brain becomes less responsive to treatment. So we then have to do more things. Yeah. And why wait until then is really a defeatist approach that we have to stop.
Yeah. Well, and I want to dig into what you said a little earlier, because I think I want to make sure they understand this about just basically how bad treatment is now. So as you pointed out, we can get outcomes, and I like to use a conservative one of like 2/3. The 2/3 of people will get better if we give them the right treatment. And the people who actually get to treatment, which is what research shows, that's what happens. But if I understand it, only less than 10% of people actually get to evidence-based treatment. And so how do we lose people along the way? Like, what are the barriers that get in the way of people getting to treatment?
So there are two things. One is there's no routine screening, routine measurements, routine assessment in primary care, pediatric practice, OBGYN practice. So what ends up happening is only those people, like you were mentioning, who lose their job or are not able to work or have problems with their social life, come to the doctor and then they get diagnosed. So there, half the people with depression in the United States never get diagnosed.
So we just to dwell on that. So we wait till they notice. We don't try to find it ahead of time. It's like waiting until the cancer grows to where you're like, oh my gosh, there's a large lump, or it's like that.
Think about how if we were to treat everybody with breast cancer only when it reaches stage 4, we would lose a lot of women that we shouldn't.
So we lose half of people. You said half of people we lose to that we just don't even find them.
We don't even find them.
Well, what happens to the other half?
The other half, when they get diagnosed, there's a whole lot of stigma around it and ignorance, so that they don't start on a treatment. They say, well, wait, we'll see, change your job, this, that. And so half the people who are aware they have depression don't get diagnosed. And then there is a lot of myths about it. These medications are bad. Well, you don't have to treat them with medications. You can go to therapy. If that doesn't work, you can go to exercise. So there's many treatments.
Yeah.
But half the people don't get treated. So only a quarter get treated.
And I think that's the thing we were able, I think, to convey to the Lone Star Prize folks is like, if we just did those two things, we found people and then we gave them treatment in primary care with a technique called the collaborative care model. And, the thing that I try to explain to people are like, well, how does that work? And I'm like, well, it's like a nurse. The doctor has a nurse to help her with doing the things the doctor doesn't need to do and the doctor shouldn't do, like, take your blood pressure, your weight, do all that stuff. Now with collaborative care, the doctor has two helpers. She has a behavioral health care manager to do the work with the patient to try to track them, make sure the treatment's going well, do some of the treatment. And then she has a psychiatric consultant for when she does need medication to make sure she uses a good one as opposed to whatever she was trained to do 15 years ago when she went to school. So it's pretty simple. Like we're basically just get them helpers, right?
It is very simple and it is very targeted, right? The reason you need the behaviorist is because, remember, one of the cardinal symptoms of the illness is listlessness, lack of interest. So the doctor says, come back in 3 weeks, and they don't show up. There is that behaviorist who calls and says, what happened? Can I help? And they come back. So they get the follow-up needed, and that makes a whole lot of difference.
Yeah. And so we've done this, by the way. Part of what we told the Lone Star folks was in North Texas, we started this. So we should probably thank at this point Dee Dee Rose, who gave us both a grant in 2018 where Dee Dee basically said, hey guys, I think you need to find people earlier. Can you go out and do that? And we said, yes, we can. We told her about these tools and she invested. And we've got now, you had a bunch of clinics already. You were working with Madhukar. We've added now Dallas Methodist Health System and Baylor Scott and White are part of the project. And I was just talking to the folks at Baylor Scott and White yesterday, and I think, at this point, just in the early stages, they're seeing rates approaching 50% just in the early stages of people getting better from stuff. So like overnight, they're starting to see these results. And I guess, is that pretty typical to be able to see it go that quickly when people start implementing?
So that is an amazing benefit of this approach we have talked about. While we have been talking about how big the problem is and how comprehensive the approach needs to be, what the clinic has to do and what the physicians and the healthcare providers have to do is actually very routine and easy to do. Once a provider starts engaging in this over several weeks, they actually become expert at it because they are smart people. They are doing care for more complicated illnesses. So they just transfer that knowledge. And yes, we start seeing effects in 3 to 4 weeks. In fact, in the 40 clinics we have worked in over the last 2-3 years, as you mentioned, we find that once we engage with the clinic and 2, 3, 4 weeks later, and definitely 2 months later, they rarely need our assistance because they are on their way. They do it. They call us when needed. Yeah. And so I am not surprised that Baylor is telling you they're already seeing effects, because that is really putting it in place is the hardest thing. Once you put it in place, it's really doable.
Well, Baylor Scott and White serves 2 million Texans a year. So that's why we're going to get so much leverage through these partnerships. The other partnership are the medical schools we're working with. We're going to work with your colleagues at, I think we're going to start with the Dell Medical School and then maybe go out, I think the Texas Tech systems, right? And Can you talk about like kind of why those medical schools are such important partners for us in this, in terms of being able to reach more of the state?
So for two reasons. One is, as you know, and you've been at the forefront of engaging that, the state legislature has engaged all the 12 medical schools together through the Texas Children's Mental Health Care Consortium. And as part of that, we have the Depression Research Network, which engages all 12. And we are improving the care of patients across the state. So we have the benefit and the advantage of having diverse populations, rural, urban, ethnic diversity, in small medical schools like Tyler, big medical schools like Houston and Dallas. And so all of these places are part of our network, and now they are all working through in a similar pattern. So they are ready to now take on these new tasks. And Lubbock is already implementing this through electronic means through our software. Dell is very excited, and their chair, as you know, Dr. Nemiroff, has been a full supporter of this effort.
Yeah, it's exciting. And I think, too, the thing I'm excited about is this also, by partnering with them, we're going to train that next generation of psychiatrists and primary care docs to practice this way. So they will get trained better than you and I got trained. And so I'm excited about it.
Methodist, our partners at Methodist Health System are going to start this project in their clinics, which are used by residents who are getting trained in primary care and family medicine. So exactly.
Yeah, well, it's so exciting. Now, I want to shift a little bit because, as Margaret said, we're not just training people differently and doing practices, we're looking at the market forces. And one thing I think folks probably don't know, because they're not tracking this, is that until recently, none of this was paid for. It was in 2017 when the Medicare system said, we'll start to reimburse this type of care in primary care. So that was only 4 years ago. And then in 2019 and 20, even before the pandemic, pretty much every commercial insurer, so Blue Cross Blue Shield of Texas, Aetna, I'm sorry for not naming you all, but all Cigna, all the insurers basically started covering this. And then we were super excited because the Texas legislature just added it to the Medicaid program in Texas, which means if it's in the Medicaid program in Texas, it's pretty much the, mainstream at that point. So we've got everybody paying for it now. And that's, I think, one of the things we were able to point out to the reviewers is like, this is sustainable. We just need to we just have to help people get this in place, and then there will be funding streams to pay for this over time. So, don't you think, we couldn't have done that, right? We couldn't do this if we didn't have a way for people to get reimbursed for it afterwards, could we?
Absolutely. I think health systems have to be viable, so therefore they have to be able to get reimbursement for the efforts they put in, and this requires changes in the way they practice medicine in order to include this in their routine care. So therefore, reimbursement is essential. So that's been a wonderful gift from the state legislature that they've agreed. More importantly, I think that, as you were mentioning, the sustaining part is twofold. One is reimbursement, and the other, as you mentioned earlier, once the health system starts doing it, they see real benefit in their patients, and they see more satisfaction for both the patients and, in fact, the providers. The clinicians are very satisfied now. Because remember, some of them were losing their patients to suicide or having repeated visits to emergency rooms, and now this allows them to track them better, so there are fewer visits to emergency rooms, fewer suicides, as you just mentioned earlier.
Yeah. Well, one of the things I'm super excited about, too, on that funding front is the federal government hopefully is going to get into this. Congresswoman Lizzie Fletcher from Texas, down in the Houston area, introduced bipartisan legislation last Friday with Representative Jamie Herrera Butler out of Washington State. It's called the Collaborate in an Orderly and Cohesive Manner, which is the acronym for collaborative care, the COCM Act. And I don't know if you saw the press, well, you did because you and I talked about it, but the American Medical Association, the American Academy of Family Physicians, the American Academy of Pediatrics, all the medical groups basically endorse this legislation that would kind of do what the Lone Star Prize is. It would provide technical assistance and then help health systems and providers do the startup. So that would be pretty cool if the federal government put $80 million into this. Lyda put in 10, so I would think the federal government could come up with 80, don't you think?
Absolutely. And I think you are absolutely, and at the risk of repeating myself, I think this is exactly what we did with diabetes care 20 years back. Until then, diabetes care was suffering the same kind of fate, and now it is better because there is diabetic nurses and other additional services included in this, and that's what all this collaborative care will allow us to do.
Yeah. Well, I want to talk about the third component which we would have talked about earlier if Vikram was here, because he would have made sure we did. But now we're going to talk about it. So our friend and colleague, Vikram Patel from the Global Health Program at Harvard Medical School has come up with this Empower approach. And, this is really important because not everybody has access to primary care. Not everybody has an easy time getting to the doctor when they need to. And this particularly impacts communities of color, people living in poverty. Before I shift, I do want to say one of the things, Madhukar, I think is really cool is collaborative care, this model. It's actually one of the few models that's been shown to work in Black communities, Latino communities, as well as impoverished communities in general. And what they've shown is that basically everybody does better if you give them their healthcare in their primary care setting, which I guess it sort of makes sense, doesn't it?
It makes full sense because some of the major components of collaborative care really directly address this area where there is need, right? The resource-starved populations is where collaborative care has the biggest impact, in fact, in some ways.
That's exciting. But then the Empower program takes it one step farther by basically training a cohort of a group of community health workers. And what they did was they did this in India. So Vikram in India trained up a group of community health workers, lay people, and taught them how to do behavioral activation and gave them sort of a way to use their smartphone to be able to get supervision and peer coaching and some of the measurement-based care we're going to do in the primary care clinics. And they had amazing outcomes just with that of helping people with depression. So we're going to deploy that now across North and Texas first. Then in year 2, we're going to work with some community organizations and experts to develop a Latino culture, Spanish language version so we could address, the majority Latino population in most of Texas. I'm super excited about that. I mean, I know you know Vikram real well. You guys go way back, but how do you see that augment? Because we've never put these two things together before.
So both of us have worked with Dr. Vikram Patel, who's really an international expert in this idea of how best to approach populations in need. And we both are on the International Lancet Commission. That actually one of the major messages from the Lancet Commission for all of us globally is to really recognize that there is a population that doesn't have either the resources, more importantly, are not directly in contact with health systems. And that's where Dr. Patel's work, Vikram's work is very essential. And we see that even in our communities routinely. There's a large population that never makes it to primary care to make the impact, right? Yeah. So they're unfortunately remaining on the sidelines, and his Empower project and approach allows community lay workers to actually go to the community and identify people and connect them to care. Yeah. That is actually the best way to kind of do the full 360 so that we're not stuck with only those who come to us, but get everybody improved.
Yeah, it's really cool. So for folks who are sad because they can't see Vikram today, he did get in that little. Did you watch the episode? So Oprah and Prince Harry have the me you don't see, or I forget exactly what the name is. So Vikram's in episode 4, and if you fast forward to 20 minutes in, he's talking about an instance of this program, I think in Nigeria. But it's really cool to watch how they basically partner. So it's not just community work. It's actually members of the community who are going to be able to help in other ways to now train them to be able to link people into this type of care. It's pretty cool. So speaking of pretty cool, we just got a couple more minutes. And I guess I just wanted to so as we look out, it's going to be 5 years from now, we're going to have this done. What are some of the things what's one thing that you're most excited about that, or that you want to, but maybe not as excited. What would you like to close with? What idea? Then I'll share one.
I think that we are going to, because we are doing this across many systems, and we are going to actually get automatically data that will showcase the impact of this in this population. My hope is this will take on so that it will be spread across not only Texas, but to other states in the country.
That's my hope too. And certainly that bill would really help with it. I think the thing I'm looking forward to is, we've been doing a terrible job on suicide and depression up till now. The pandemic, I think, was really hard. But one of the things I'm most worried about is the effect on young people. We're seeing rates of suicide going up among youth of color, among young women and adolescent girls. We're seeing, it's at historic levels. And it's the second leading cause of death. And I think that's the thing I'm most hopeful about. I guess excited maybe isn't the right word, but it's such a tragic trajectory that we've been on for the last decade of increasing rates that I feel like to be able to bend that and be able to offer young people and families, including families who may not have easy access to healthcare, some options so we save more people and don't have to have another family go. Well, we are going to have other families. We're not going to be able to reach everybody, but I think we estimated about 1/6 to 1/3 of loss of life from suicide could be helped through this model. And
just one quick thing in the attempt to reduce suicide, which we want to, we will actually also help a whole lot of people that will be not suicidal but still have depression that improves. So I think this approach is essential, and yes, we will reduce suicide rates.
Yeah, I think just to give folks an idea, we're hopefully going to save about 1,000 people from suicide over the period, which will hopefully escalate over time from them. But there'll be millions with depression, so it's exciting. Well, Madhukar, thank you so much. It's so much fun to get to do this with you. I'm really glad that we've had this opportunity, and thanks for talking.
Thanks to Lyda Hill Philanthropies. Thank you.
Absolutely, and thanks to this series. Take care.
Well, it is hard to believe that we are at the close of our first day of Big Bang. The content has been fantastic, great thought leaders, wonderful ideas, great innovations taking place. We are so grateful to our audience who engaged with us, and what a great conversation we had, and I hope the audience really enjoyed our day, as did we. We invite you to come back tomorrow at 8:10 a.m. with a powerful conversation with the Texas Women's Foundation on stopping the backslide. And a conversation I am so looking forward to that I know you will absolutely enjoy is with Darren Walker and our own rock star here locally, Jennifer Sampson, the CEO of the United Way. We will have more breakouts, and you will have a great session with the incredible Ear Hustle team. So once again, we thank you for being with us today, and we look forward to seeing you tomorrow. And remember, do good better. Thank you.